Hello, today I'm going to be demonstrating a complete head-to-toe assessment. So to begin the assessment, like all assessments, I am going to start by washing my hands, introducing myself, asking permission, and explaining what I'm going to be doing. So, hello, my name is Elizabeth. I'll be your nurse today. I'm going to be doing a head-to-toe assessment on you. Are you okay with that?
Yes.
Okay, so to get started, I'm going to start off with vital signs. So we'll first just get a temperature. Is that under your tongue? Under, yeah. Excellent. 37. And then I will get a blood pressure. Just raise your arm. Okay, and then just go ahead and relax your arm. And this is going to get tight. Blood pressure was 123/78. I would then get an O2 saturation with a monitor, and then I'm going to get a pulse by feeling for his pulse and counting for 60 seconds. Okay. And now that the vital signs are done, we will move on to the first system. When performing a head-to-toe assessment, you can either go system by system or go top to bottom, whatever makes most sense for you. For the sake of this, I am going to go system by system. So the first thing I'm going to look at is the skin. So when I'm looking at the skin, it's important to assess the whole body. So the patient would be unclothed for this. We're looking at the head, the torso, the back, and both extremities. We're just looking for the general appearance of the skin. We're noting any lesions, any scarring, any open wounds, rashes, things like that that you may notice. And then we're going to look at the nail beds here and look for any clubbing of the nails, which is when they have a wider kind of swollen and downward slope. It could indicate some heart problems, so I'm just going to look at the nails there. Okay. I am then going to palpate the head, noticing any bumps or irregularities. While I'm doing that, I'm also looking at the hair distribution of the head. So I'm just going to palpate the head here, looking for symmetry, noticing any bumps, noticing the hair distribution. And then as part of the skin assessment, I'm also going to look for edema. So any swelling, it's important to look at the whole body, as sometimes it can be in like the back or the buttocks. I'm just going to look at the hands and then also his lower extremities, the feet and the shin area too. He does not have any edema. While I'm looking at the skin, it is a good time to look for any varicose veins or any veins that are protruding out of the skin or enlarged, and these oftentimes will occur on the back of the legs but could be anywhere, so I'm looking for those. And then the last thing I'm going to do for the skin is just note the skin turgor. So this is a test for dehydration, so I will pinch the skin, and if it returns to normal quickly, that means the patient is hydrated. If it has a really slow return, it could mean a dehydration. It should return in like less than a second. So good places to pinch are on the chest, and then just on the arms or on the lower legs as well. That concludes the skin assessment. Moving on to the head, ears, eyes, nose, and throat part of the assessment. The first thing that we're going to look for is cranial nerves 3, 4, and 6. So cranial nerve 3 is going to look at Perla to see if the eyes are equal or unreactive to light and to accommodation. So to do that, I'm going to take my pen light. Okay, so I'm going to take my pen light, and then I am just going to have the patient look straight ahead and then shine the light into it to see if the pupils constrict. And I will do that on both sides. So look just straight ahead for me and open your eyes. Yep. Okay. And then this eye, bright light. Okay, and then to look at cranial nerve 4, the trochlear nerve, we are going to use the light again and have the patient follow the movements with the pen light with their eyes only. And we're going to go upward, downward, sideways, and diagonally. So go ahead and just look at this light for me, and then just follow it with just your eyes. Okay, over here. And then we will also look at cranial nerve 6, which is the abductus. So what I'm going to do with this is have the pen light go through the 6 cardinal fields of gaze. So again, just follow the pen light over here. So look over here and down, and you can just do this with your finger too. Up, then up and down. And then the last thing we're going to do to see if the eyes are reactive to the accommodation is to have the patient look at my finger or the light, and then look beyond it to see if the pupils constrict with that. So go ahead and look at my finger, and I'll look at the wall behind me, and then back at my finger. Okay. The next thing we are going to look for on the eyes is just note the color of the sclera and the conjunctiva. And the sclera is the thick layer that forms the white of the eye. So you just want to make sure that that's white. There's no like redness, any abnormal discharge. And then we just want to make sure that the conjunctiva, that thin translucent membrane that covers the inner lining of the eyeball, is also not noticeable or red or anything. So I'm just going to look in the eyes here. And then the next thing we're going to do for the eyes is test the vision. So I'm going to use a Snellen chart. Okay, so with my Snellen chart, which we've all probably seen before with all the letters, I'm going to stand 20 feet away from the patient and then have him read the lines the smallest that he can. And then it says what the vision, the 20/20, 20/30, 20/40, etc. is. So I'm going to be 20 feet away, and then go ahead and just read the line that's the smallest that you can see.
PEZOLCFTD.
Excellent. And that made his vision about 20/30. So now we are going to take a look at the mouth and the throat. So I am just going to be inspecting it for the color and the lesions. I'm going to be looking at the oral mucosa. I'm going to be looking at the gums, make sure they're not swollen or bleeding. I'm going to look at the tonsils and the base of the tongue, the oral pharynx, as well as just the tongue itself. And then I will also look in the nose as well at the nasal mucosa for color, intactness, lesions, if it's swollen, any excessive or abnormal discharge. So to do that, I'm going to take my light again and just, why does that never turn on? Just have the patient open their mouth, okay, and then stick your tongue out, okay, back in, and show me your gums, okay, and then I'm just going to look up each nostril, and then I'm going to look on the other side. The next part of the assessment is to be palpating the thyroid gland. So for the thyroid gland, I'm going to stand behind and kind of just cup the neck like this. And I should actually not be able to palpate the thyroid gland. If I could, it could mean that it is enlarged or has a mass. And then while I'm here, I'm just going to also feel some lymph nodes. So I'm going to feel first the submandibular, which is just under the chin here. So again, I'm just going to kind of use 2 fingers and just kind of feel. And the lymph node should be non-tender, and a little bit mobile. If they are really fixed and tender and hard, that could mean some swelling. And then I'll also feel the cervical one. So if I come down here and feel kind of in front and behind and right above that clavicle. And then moving on to the ears, I'm going to visualize the ear canal and the tympanic membrane. So I'm going to lift the lobe up and back using my light, and I'm going to look for the membrane to make sure that it is nice and pearly white and ovum and semi-transparent. What I don't want to see is like redness, swelling, stuff like that. Right, so I'm going to take my otoscope, pull up and back, and then just get a good visualization of the ear. I'm noting some earwax, very normal. Okay, and then I'll go to the other side. And the same thing, comparing both sides. After visualizing the ears, we are going to test hearing acuity. And to do this, I'm going to perform the whisper test. So I'm going to have the patient plug the ear by pushing in on the side I'm not on, and I'm going to whisper like a 2-syllable word and have him repeat it. So go ahead and do that. Baseball.
Baseball.
Apple.
Apple.
Okay, and again, I would do that on the other side. And then the last part of this assessment is going to be the Rhine and Weber test, which is going to differentiate between conductive hearing loss and sensory hearing loss. So for both of these tests, I'm going to use a tuning fork. So with the tuning fork, I'm going to get it going, and then I'm going to put it on the patient's top of the head and ask you to hear it on the right side, left side, or both.
Both.
Okay. And if you only heard it on one side, that could mean a problem with that opposite ear. And then for the Rhine test, I'm going to do the vibrating tuning fork and place it on the bony prominence on the back of his ear. And as soon as he can no longer hear it, I will then move it forward to see if he can still hear the vibrations. So tell me when you can no longer feel that or hear that.
Can't hear it.
Okay. Can you hear it now?
Yep.
Okay. And again, I would do that on both sides to make sure that both are compared. So that concludes the head, ears, eyes, nose, and throat part of the assessment. I am now going to move on to the respiratory. All right, so for the respiratory system, I am going to start with just the general inspection. And I'm just looking at the symmetry of his chest. I'm looking to see if his respirations are super shallow or very deep. Seeing if he's just having any noticeable trouble breathing or work of breathing. And then I'm going to palpate for symmetry. So I'm actually gonna have you turn around for this. Okay, and so in order to do this, I am going to place my thumbs kind of along the very last rib, that 10th rib here. And I'm just gonna kind of pinch in to get a little skin fold and have him take a big deep breath in. And when he does that, my thumbs expand, and they should be expanding. You can breathe normally. They should be expanding symmetrically. If one side versus the other goes, it could mean asymmetrical breathing. Okay, and then while I have him backwards like this, I'm going to do some percussion. With the percussion, I'm going to just use 2 fingers on my dominant hand and use my dominant hand to just, one finger and just tap on it. For my percussion technique. And I want to hear a nice resonant sound because the lungs are filled with air. If I get over a rib or a bone, it could sound dull. And so I'm just wanting to do that along his back. And we also don't want to forget to percuss laterally to hear those side lobes. So I'm just gonna kind of go from side to side and just work my way down. Again, if I get over the scapula, it's going to be dull, or over a rib. Making sure I get the bases of those lungs, and then the side as well. Okay, and next, after percussion, I'm going to do auscultation. So I want to go in a lateral position and always go from one side to the other so I can compare. I will listen to the back and the front. I'll start with the back. And I will have him take a big deep breath with every listen before moving on. Sorry, this is a little cold. Okay, big deep breath. Let it out. And then just every time my stethoscope touches, take a deep breath. Yep. And I'm going to do 8 spots total on the back, 4 on each side. And when I'm listening to the lung sounds, I'm making sure that they are clear and equal on both sides. Stuff that you could hear is like crackles, which is a core sound, wheezing, which is really common in asthma or bronchitis as the air is getting constricted and can't get out. Rhonchi means really coarse and rough sounds, kind of wet. But his lungs were clear and even on both sides. And then go ahead and flip around and now you will listen, auscultate the anterior side as well. And I'm just going to go above one clavicle and then the other. So same thing, just deep breath. And then kind of these side lungs as well. Okay, and that concludes the respiratory system for our assessment. So for the cardiovascular assessment, I'm going to first start with inspection as always, and I'm just looking for any noticeable heaves or lifts. So if I'm just, noting if there's any noticeable heaves or lifts in the chest. And then I'm going to palpate the PMI, the point of maximum impulse on the heart, also known as the apex, which is going to be mid-clavicular line at about the 5th intercostal space. And so I can just palpate. And I'm noticing just rate, rhythm, and quality of that palpation. And then I'm also going to palpate the radial and the pedial pulses. So I will want to do this on both sides. So for the radial pulse, you'll see it right here on both sides. And then palpating for strength from 0 to 4. 0 is no pulse. 0 is no pulse, 1 is faint, 2 is diminished, 3 is normal, and 4 is bounding pulses. And then I'm also going to do the pedial. So for the pedial pulse, I will feel just relax your leg. Yep.
Can't see it.
On just the top of the foot here. And I will feel both sides to compare. And part of this assessment, I'm also going to look for a cap refill. So while I'm down here, it's a good time to do that. So I'm just going to pinch just relax your foot there. I'm just going to pinch the toenail, kind of watch it go white and then see the blood return. And I will do that on both toenails and then also on the fingers as well here. And the cap refill should be about less than 1 second for it to pink up. And then the last part of the cardiovascular part of the assessment is going to be auscultation. So I'm going to listen to heart sounds. I'm noticing the rate, the rhythm, the quality. I'm listening for S1 and S2. I'm noting any murmurs or any irregular or extra beats in there. And I'm going to listen with the belt and the diaphragm of the stethoscope. And I'm going to go in 5 different points. So I'm going to start about 2nd intercostal space on the right. And then I'm going to go over to the 2nd intercostal space on the left. And then I'm going to kind of just slowly inch down each space. So the 3rd, the 4th, and the 5th, and then the apex of the heart. Okay, and I'm going to do the same thing, but listen on the other side of my stethoscope as well. And just inching down. Okay, and that concludes the cardiovascular part of the assessment, we are now going to move on to the gastrointestinal. So for the gastrointestinal examination, it is easiest to have the patient lying down. And the first thing I'm going to look for is just overall like nutrition. Is there obesity, any evidence of any eating disorders, anything like that. And then I'm going to inspect the abdomen for symmetry, for the shape and distribution. Is it even? Does he have any hernias, which are major bumps sticking out, and also any like pulsations that I can visualize. And then next I'm going to auscultate his bowel sounds. So we'll auscultate before we palpate or percuss. So I'm just going to listen to bowel sounds in all 4 quadrants, and I should hear some gurgling. And then I'm going to just palpate the abdomen for any masses, and then just let me know if there's any tenderness with any of this. This is just more of a soft palpation. And then I'm going to use my percussion technique I demonstrated earlier to percuss over the liver, which should be tympanic. And the liver is kind of in the upper right quadrant here, so I'm just going to percuss. Sometimes it's a little hard to hear. There we go. Excellent. And then the last thing I'm going to do is test the McBurney's point to see if there's any tenderness over the appendix. So what I'm going to do with that is push down, and then I'm going to lift up to see if there's rebound tenderness with that. So it's just kind of in this lower quadrant here. I'll push down and then release quickly. Any tenderness with that?
No.
Okay. So that is it for the GI. And then moving on to the GU, I'm just going to kind of inspect, palpate, and percuss over the bladder, looking for distension and looking for tenderness. Down just a little, so I'm just going to do some light percussion, or palpation, and then percussion. Again, it sounds different when there is liquid in the bladder versus not, and noting any tenderness. And then the last part of the GU assessment is going to be looking at CVA tenderness. So I'll actually have the patient sit up for this and show their back. So for the CVA tenderness test, we are going to kind of visualize where the kidneys would be on this part of the back, and actually kind of do, instead of just like the percussion with the 2 fingers, a little bit harder, kind of a pound. And you can do it kind of in 2 different spots on each side to see if there is any tenderness with that. Moving on to the next system, which is the musculoskeletal. We're going to start by testing range of motion. I'm not going to do every part of range of motion because this is just kind of a general head to toe assessment. So I'm just going to look at the shoulders and the hip joints. And when I'm doing this range of motion, I'm looking for crepitus, popping, clicking, pain, stuff like that. So with the shoulders, we will do extension. So lift your arms out, yep. And then bring them down, yes. And then we can lift the arm out and abduct and adduct. So go ahead and turn your arms in and out. And then we will also do extension, so across, yes, and on both sides. Okay, and then moving on to the hip joint. So turn to the side, and then we will do flexion and extension of the hip. Yep, and then turn to the front and do adduction and abduction. So out and in, and then internally and externally rotate. Excellent. And we do that on both sides, of course, to compare. Okay, and then for the musculoskeletal, we are going to test strength. So the strength is a rating 0 to 5. 0 is no movement at all, and 5 is strength with resistance. So first we'll look at the arms. So the bicep is first, so go ahead and I'm just going to push down his arm and have him try to pull up. Okay, and then the opposite for the tricep. And then we'll do the wrist, so I'm going to have him make a fist and then go up against me and down. And then we would do that on both sides to test the strength of the wrist. And then we'll do the shoulders. So I'm going to just put some resistance and have him lift up. And same thing on this side. Okay. and then we will test the strength of the legs. Okay, so for the legs, I'm just gonna put my hand on his shin. Just relax your legs here. And then push up against my resistance on this side. And then we'll do the ankles. For the ankles, go ahead and let your foot dangle. And we'll put pressure on the top of his foot and then go ahead and push up, yep, and then push down against my foot. Excellent. And then we're of course asking about any pain with any of these movements, especially against the pressure. The last part of the musculoskeletal is just to look for scoliosis. So I'm going to have him stand up, and then I'll have him just kind of bend over, so act like you're touching your toes. Excellent. And then with his shirt up, I will just look at the spine to see if there's any curvature, and then just feel the hips to make sure that they are even. Okay, go ahead and stand up. So that concludes the musculoskeletal, and now we will move on to the last system, which is the neurological. So for the neurological assessment, we will start off by noting if the patient is oriented to person, place, time, and situation. These are also good questions to ask kind of at the beginning of the examination, so it isn't so random in the middle, but that's okay. So can you tell me your name?
Bob Ross.
Can you tell me what day it is today?
Sunday,
Okay, and what month?
December.
Yes. And where are you today?
At home.
Okay, at the clinic getting an
The
assessment.
clinic.
And can you tell me why you're here?
To get an assessment.
Yes. So he was alert and oriented to all 4 of those. So the next thing we're going to do is just test grip strength bilaterally. So I'm going to put 2 fingers out and have him squeeze both my fingers. And just making sure, like, give me a good, like, yes, there you go. Making sure that that's equal and strong on both sides. And then I will look at the patellar and the Achilles reflexes. So I will take my reflex hammer. Okay, so I will start by checking the patellar on both sides, which is just right below the knee here. So I'm just going to have the patient dangle the leg and then just strike and then look for movement. I'll do that on both sides. And if you're not getting any reflexes, you can have the patient pull their arms apart to distract them, kind of do that. And then for the Achilles, kind of same concept. I'm just going to strike on the Achilles tendon to see movement and just kind of relax your foot. There we go. And I would do that on both sides. And then part of the neurological assessment is assessing the gait of the patient, which I did when he walked into the room. I'm just noticing that it's symmetrical and even. He doesn't have a limper. He doesn't favor one side versus another. He doesn't do super short strides or super long. And then we are going to test cerebellar function. So the first thing we're going to do is kind of test the balance. So go ahead and stand up, and I'm going to have him stand here with his eyes closed for about 30 seconds, and I'll just kind of put my arms here in case, and just notice any movement. So go ahead and close your eyes. Okay, there's slight swaying, but nothing like he can't hold his balance or anything. Excellent, you can sit back down. And then the last thing we are going to do is the Romberg test, which is just some sort of rapid alternating motion. So I'm going to have him just like slap his thighs and then come up and yep, and then do that fast. Okay. So that is just tests for that cerebellar function with the Romberg test. So that concludes my head to toe assessment, focusing on each body system. And obviously, if anything was abnormal during that test, we could do a focused assessment on that system. So thank you for watching.